everyone, and welcome to the third edition of this webinar series of the CANM. My name is Nicolas Rondeau-Lapierre, and I will be your virtual assistant tonight. Thank you again for joining us. We'll wait a little 60 seconds for the late registration, just for the login. So please, just a little patience. We'll wait a minute and we'll be right back with you guys. Thank you. Voilà. Again, everyone, bonsoir, bonne soirée à tous. My name is Nicolas Lapierre, and I am your virtual assistant for tonight's session. What is a virtual assistant? Let's jump right into it before we get the actual presentation going. So, virtual assistant, I will ask you to know how this software works so you're comfortable with this webinar. So familiarize yourself with the control panel, ensure your audio is working. You have an option to phone if ever your audio is not working from your computer and or mobile device and whatever you're using. Attendees are automatically muted. You don't have the option to unmute yourself. You have two handouts, protocols that we for attendees if ever you need a bit more information on how to navigate this interface. There will be a Q&A session after the presentation, so please send us your question and we'll get to as many as we can after the presentation. And you can access the question section by the little question mark. Just find a question mark for anyone that's on a tablet, phone, mobile device. Find that little question mark and then ask your question. That's it for me. I will be in the background if ever you have any need for technical support. And then there you go. So right now I will present you tonight's moderator, Dr. Peter George Malia. So Dr. Malia, the floor is yours.
Thank you, Nicolas. It won't run so smoothly without your help. Welcome everyone to the third edition of the webinar series of the CANM. Bienvenue à tous pour la troisième édition des séries webinaires du CANM. We're really happy in such great numbers. You're already 96 logged in. We're expecting 170. These webinars are one of the greatest ways to keep us together in these difficult times in which you can't really see each other and to let us share knowledge. And that's what I will introduce our speaker of tonight. So here tonight is moderator. He used to be my resident when I was a medical student in neurology. So I'm with him. I have rounds is his trademark. Neurologist and clinical assistant professor at the Centre Hospitalier in Montréal. He completed the Bachelor of Philosophy Science thesis entitled Interaction of Saccadic Eye Movements and Visual Perception, the Montreal Neurological Institute of McGill University. His PhD, he attended the University of Calgary's Cumming School of Medicine, followed by residency training in adult neurology at McGill. He pursued fellowship training in disorders and cognitive neurology at DaTScan Medical Center, Harvard Medical School. Dr. Richard's clinical interest disorders include Huntington's disease and deep brain stimulation. So Dr. Richard did a delay until he sets up his webcam. So During that time, I encourage you to ask all the questions you have in the question mark section, Q&A. I'll ask them during the presentation, as I will be accumulating them and putting them together and asking the questions at the end. We're waiting, and that's that.
Okay. Can everybody see me okay? I hope everything is working well. So thank you very much, Peter, for the kind introduction. And it's really great to see you again. On a personal note, I do remember our ice cream rounds. And as I said a moment ago, I'm trying to revive that tradition at the CHUM. Thank you also. I'd like to just quickly thank the CANM for inviting me to give this lecture. It's a really great pleasure to basically provide this introduction in a sort of way, but also hopefully expanding on what people already know about Parkinson's. So I'm going to be focusing mainly on how we approach Parkinson's and Parkinsonism, and you know, trying to incorporate as well some concepts about medical imaging at the right point in the presentation. I'm very interested to hear people's thoughts on everything, of course, and I'm excited to be a neurologist presenting to this audience. It's a great opportunity. So with that, I'm going to go ahead and start. Disclosure slide quickly. It's a quickie. Basically, I have no disclosures. You'll notice that there's a beautiful piece of art here, and I've tried to spread some interesting examples of art throughout the presentation from artists that who are painters, but also who happen to have Parkinson's disease. And I wonder if people will recognize some of them, maybe be surprised by some of the ones that we see. So just to give people a sense of the outline, as I said, I'm going to go in really to a basic talk about Parkinson's. And to do that, I'm going to provide a bit of historical perspective. And then we're going to go into the differential diagnosis of Parkinson's a little bit before focusing on idiopathic Parkinson's disease and the different features of that disease, the motor and non-motor features. I'll try to say a few things about the pathophysiology and also get into the diagnostic criteria. So really that's the goal of the lecture, is for people to be able to leave with a good sense of how a neurologist, how a movement disorders neurologist thinks about Parkinson's and thinks about the approach to an undifferentiated patient. So just by way of general orientation, I realize that I'm speaking to an audience largely of physicians, but also I think there's a good spread of other types of people. So, you know, it is a neurodegenerative process, and it's one that we don't have a cure for. So when I'm introducing the concept of Parkinson's to patients for the first time, I usually make that clear and make that explicit. And I think it's important for them to appreciate that it's something that will get worse over time, like any other neurodegenerative disease. It's very common in our society. It affects about 1% of people over 60. It's only eclipsed by Alzheimer's in terms of other, you know, a more common neurodegenerative process. And the mean age of diagnosis is around 70, but there's a lot of spread in that, and it depends on the type and it depends on the circumstances. For example, genetic Parkinsonism can often present younger, in the 40s and 50s even. So getting into the history a little bit, this is an entity that's been known, or at least described, for I think hundreds of years at this point, which is very interesting and always fun, you know, to sort of remind yourself that as a physician who sees patients. A lot of people will be familiar with this essay by James Parkinson, which was published in 1817. And it was really just a beautiful description of what he was observing. He wasn't describing it as a disease or a syndrome at that point. It was just, he was making some observations about patients that struck him and that seemed to he was able to group patients according to these features. So just as a quick excerpt, which I thought was such an elegant way to capture some of the main features. He talks about involuntary tremulous motion, in parts not in action, and even when supported, with a propensity to bend the trunk forwards and pass from a walking to a running pace. The senses and intellects being uninjured. So, you know, he's talking about a lot of the cardinal features that we often associate with the disease: the resting tremor, the hunched posture, and of course the festinating gait. And you know, a lot of the time, but not always, people will present these motor symptoms before they present any cognitive symptoms or issues. So we all know about James Parkinson, but it might interest some people to know that Charcot was actually pretty instrumental in actually describing the syndrome. And he did that later. He did that many years after Parkinson produced his monograph. We actually had a formal disease definition by Charcot, where he really focused in on the slowness, the bradykinesia, the autonomic features, and also the pain that can be a prevalent aspect of the disease. And for fun, I'll draw your attention here under the Charcot's name. He published his findings in the American Journal of Insanity in 1893, which I thought was interesting, just to think about how these things were propagated back then. So an important distinction about Parkinson's is that, you know, we differentiate, language is important, and we differentiate Parkinson's disease from Parkinsonism. Parkinsonism is a bigger umbrella term that encapsulates things you can observe on an examination. And it really does refer to a constellation or a group of different symptoms that are all part of a disease presentation. And these are things people will have heard about. So bradykinesia, rigidity, a resting tremor, loss of postural reflexes, so the inability to catch yourself if your posture is suddenly disturbed, the posture and the freezing. And it's important to realize that a lot of different diseases can cause this constellation of symptoms. And Parkinson's disease is just one of those many possibilities. Certainly probably the most common or the most famous. But it's a distinction that I do take the time to make with my patients. And it's also a distinction that I remind myself as a clinician often, because it's important to work through the differential. And we'll get into that right now. Here's one of the early actually drawings, by the way, of a patient who was considered to have Parkinson's. But if you look at his gaze and his furrowed brow, this is something that, you know, people have called rhizus sardonicus. And it is a feature that you can see in Parkinson's, but you also tend to see more classically in atypical variants. So just to kind of introduce us a little bit to the different types of symptoms we can see, I want to show you a couple of quick videos. Hopefully the sound will be somewhat audible. But what you're about to see is a patient who's reciting the months of the year going forwards. And I'll just play it so that we can appreciate what's going on.
May, June, July, August, September, October, November, December.
So hopefully people will be able to appreciate that the way she was speaking wasn't entirely normal. What I would want to draw people's attention to is the nasal quality of the voice. And also the fact that she got out of breath before going through all 12 months. And she also had a bit of a stridorous component to that as well. So that's something that we can often see in multiple system atrophy, which is a variant of Parkinson's or an atypical variant. And here's another video Same routine. This woman's going to be reciting the months of the year, and in this one, the interesting feature has to do with the pacing of her speech.
January, February, March, April, May, June, July, August, September, October, November, December.
So again, hopefully people will be able to get a basic idea or impression of the fact that her pacing was off, and she spoke rather quickly, and she enunciated the syllables quickly in sort of clusters. Almost, you might also describe it as a pressured speech type of phenomenon, but the term we use in movement disorders is tachyphemia. Tachy for fast, phemia for syllabic expression. And, she's someone that is afflicted with progressive supranuclear palsy, which it's a common symptom we see, but again, can also present in Parkinson's. So just to show you some different features. Now, expanding on the differential, most clinicians will, if they're not sure it's Parkinson's, but they think it's something under the umbrella of Parkinsonism, they'll consider the Parkinson's plus syndromes. And really this refers classically to a triad of things. So, we just saw an example of tachyphemic expression, which you tend to see most often in progressive supranuclear palsy. But this syndrome, has other features that differentiate it. Often you'll see eye movement abnormalities, as the name denotes, and really this refers often to a difficulty making vertical gaze, vertical saccades, but it's an extraorbital sort of extraocular movement palsy that affects all types of movements. The features of the Parkinsonism in terms of the slowness and the stiffness usually are more symmetric, and people with PSP will often have early gait and balance problems. So they have falls early, more to posteriorly than anteriorly. The other thing we talk about often in the differential of Parkinson's plus is multi-system atrophy. There are different types. There are Parkinsonian types and cerebellar subtypes, and this really relates to the different features we'll see on the exam, and of course where the pathology exists in the brain. This disorder is largely characterized by early and severe autonomic dysfunction, and its symptomatic management usually aimed at dealing with things like orthostatic hypotension, issues with dysuria, issues with perspiration that can really impact people's quality of life. And the prognosis of MSA is generally much worse than Parkinson's, and probably of the three, the one with the most dire prognosis in general, because it progresses more quickly. The third thing we talk about is cortical basal degeneration. This will also be referred to as cortical basal syndrome. There are distinctions to be made there, but the idea here is that the pathology is a bit different in terms of the protein that gets laid down in the brain, and it's also the presentation is quite variable because it tends to mostly affect cortical regions, and it can affect essentially any cortical area. So, on examination, you'll look for things that we call cortical signs, things like neglect, things like aphasia, things like an alien limb or a dyspraxia, and that you can usually map to a region of the cortex that's affected. And like the other two, it tends to move a little more quickly than Parkinson's, to be sure. Here on the right, I'm just showing you some classical pictures of some of the MRI findings you might see in these diseases. On top, we see very pronounced midbrain atrophy, which people refer to as the penguin sign or the hummingbird sign, because that midbrain gets so narrowed and sinewy that it looks like the beak of a bird. The pons, meanwhile, is preserved. And then here in an axial section underneath of the lower brain, at the level of the pons, we can see what's referred to as a hot cross bun sign for MSA, which is selective degeneration of these transverse pontine myelinated fibers. So this is, these are findings that people read about, that we occasionally see when we work up the patients, but honestly, they don't have to have these signs to have the syndrome. They're bonuses if you get them. This slide here is not meant, I'm not going to go through it in detail, obviously. It's more just meant to give people a sense of how expansive the differential really is for Parkinsonism. And, you know, essentially what we're doing when we're meeting someone for the first time and going through their story and examining them is we're ticking off different these different possibilities, and you know, basically recruiting evidence in favor or against all of these different forms of Parkinsonism. Some that I'll draw your attention to, you know, you're always going to want to consider Wilson's disease, because it is somewhat treatable, and you see that more in younger patients. Likewise with DOPA responsive dystonia, this is something that you'll often see in younger patients. It's a genetic disease, but again, treatable, so it's important to always think of. There's a lot of rare things here. Frontotemporal dementia with Parkinsonism is fairly common, and usually you'll be thinking about that in when you're trying to differentiate Alzheimer's from Parkinson's dementia. And you know, then there are some more esoteric things that I've listed, again, mainly just to impress upon you the idea that there are a lot of possibilities. And these are different primary causes of Parkinsonism, but we also have to think about secondary causes, and that's its own differential. And you know, these are the big themes that I want to remind people of. So of course you have to consider infectious issues. HIV can produce Parkinsonism. CJD is extremely rare, but we do see it. We see there's about a 1 case per million in most populations, and you know, we'll diagnose a case every year or two here in Montreal. You know, something that we focus on a lot, and that's going to be relevant for some of the sections of this talk later, are drug-induced Parkinsonism, which you'll often see in the context of neuroleptic medications, people who are treated for psychiatric syndromes, but also people who take antiemetics chronically. Sometimes lithium will also do it. So in patients with psychiatric comorbidities, you always need to be looking for these and considering them. There are exposure-related causes of Parkinsonism that I've listed here in terms of methanol, manganese, pesticides, and then vascular Parkinsonism. And that's an important one just because there's a high amount of vascular morbidity in our society. And we often see this presenting in the context of stroke or heart disease. So now I'm going to focus on idiopathic Parkinson's, which is the bread and butter of most movement disorders neurologists. And I'm just going to sort of approach it from a very basic perspective to give you all a sense of what it is and what we think about. So it accounts, as I mentioned, for most cases of Parkinsonism. It's a little more prevalent in men, and the age of onset is usually around 65 or 70. There are genetic factors, as I mentioned earlier, for people that might have younger presentations. And we know that people who have first-degree relatives with Parkinson's are slightly more at risk to go on and develop it themselves. This is a beautiful piece of art from a Canadian Indigenous painter who I would encourage you all to seek out if you don't know him. There's a lot of his work in the National Gallery of Canada, which we're, you know, in Montreal, we're lucky to have access to relatively close. So getting into the pathophysiology of Parkinson's, you know, when we talk about protein deposition and the part of the brain that produces the classical motor symptoms of the disease, we talk about the substantia nigra, specifically the pars compacta. And you need to actually lose quite a few of your dopamine producing neurons in this region before you become symptomatic. Usually it's around 70–80%. And here you can see a gross pathology slide showing a section of the midbrain. And on the left here, we have a Parkinson's patient compared to a normal patient on the right. So you can see this sliver of black pigmented cells. That's a substantia nigra, and those are, you know, conspicuously absent here in the Parkinson's brain. And this here is just meant to show some intracellular aggregations relating to the synuclein, which we'll get into in a moment. This is a table to outline some of the genetic causes that we see and we think about in those younger patients. These are being identified all the time, in fact. So this is not a comprehensive list. These are just the ones that I thought were the most compelling and interesting to know about. I'll draw your attention down here to the Gaucher presentation, which is relates to the gene encoding for glucocerebrosidase. This is important if you live in an area that has a high proportion of Ashkenazi Jewish people residing in it. I always ask about background if I think this might be something that's relevant, because it does travel in that population more than in others, and it's more and more popular as a genetic variant that we recognize. So these are just some examples. LARC2 is the one we will often also think about. Also common in Ashkenazis, but you can also get it in people from North Africa. So clinical features of PD, I had mentioned some of these a moment ago, and we all know this, especially those of us that have gone through medical school. We all know this as the acronym TRAP, the trap of Parkinson's disease. I won't spend too much time on it, but just to clarify terms, when we say bradykinesia, this is something that we examine and that we can observe when we're interacting with the patient. And it usually refers to both a slowness of movement, but also a reduction of the amount of movement. Classically observed as a decrement when you ask them to do repetitive movements. So that's something that's valuable to look for, and in fact, critical if you want to make the diagnosis of Parkinson's. The other thing that you'll look for is rigidity. This has to be examined carefully, of course, and differentiated from things like spasticity. And it's fairly obvious in Parkinson's in the earlier stages. And similarly to tremor, actually, you'll often observe the rigidity more on one side of the body than the other. So that asymmetry is also a strong hint that you're dealing with idiopathic and Parkinson's disease. The resting tremor we always refer to, we sometimes call it pill rolling tremor because it will manifest more distally at the beginning. It has a specific frequency signature between 4 and 6 hertz often. And usually another telltale sign about resting tremor is that it'll be reduced or even abrogated while you're moving. So, you know, patients will say, well, they're doing things that the tremor is not very bothersome, but they'll notice it when they're sort of quietly sitting down. If they're watching television, it'll sort of emerge, or if they're distracted. And that's often consistent with Parkinson's tremor. And then when we talk about postural instability, we really talk about the ability to catch yourself when your sense of balance is perturbed. We'll test this with a pull test clinically, but often patients will report, you know, just not being able to catch themselves if they trip over something, or if they're navigating a complex environment, their reflexes just aren't as sharp. So, so those are the main things we talk about. Now, those are the motor symptoms, the TRAP. But of course, Parkinson's involves almost every body system. And so there's a whole panoply of non-motor symptoms that are important to think about when you want to diagnose Parkinson's disease. And, you know, I think this kind of represents it nicely, as the things you observe on the surface are really just a small part of everything that can be affected and that is going on. So I'll try to get into a few of these now. Painter named Hans Magden, who was a veterinarian, who developed his Parkinson's symptoms in his right hand at the beginning, and taught himself to paint with his good left hand before that became symptomatic, which I always thought was nice because he he's obviously very talented, even with his non-dominant side. So let's get into some of the non-motor symptoms that we have to think about, and we often do think about when we're looking at Parkinson's. So dementia is a big part of Parkinson's. It affects a lot of people. A high proportion of people will have cognitive symptoms, up to 40. I feel like that number might even be closer to 50 or 60, based on my own experience. People will often take care to diagnose or to think about the temporal sequence of dementia with respect to the motor symptoms of the disease. So if the dementia precedes the motor symptoms by about a year or so, you tend to call that Lewy body dementia, whereas if the motor symptoms happen first and the dementia follows, that seems to be more the pattern of classic Parkinson's. As a movement disorders person, you know, it's interesting to know about that sequence, but I do consider them both the same disease, because the pathophysiology is actually the same in terms of what's going on in the brain, and the treatment is roughly the same. So that's just a small nuance point, that, you know, Lewy body is something that we talk about as a separate disease, but it's actually pathologically the same thing as Parkinson's. And here's a picture of Robin Williams, who was posthumously diagnosed with Lewy body dementia. Mood symptoms are important to talk about next, because they have a major impact on quality of life and actually on disease progression. And I find, you know, one of the more challenging but also interesting aspects of my practice is that I think about mood disorders and depression a lot, and I've been learning a lot, you know, as I see more patients, about how best to treat this and how best to respond to this, because it has a major impact. All patients should be screened for depression and anxiety issues, because again, they're treatable for the most part, and they not only have a big impact on quality of life in and of themselves, but they have a big impact on how the patient sees themselves and sees their disease. And also, you know, there's, in certain ways, their level of motivation to engage in things like physical therapy, exercise, and even being compliant with their Parkinson's meds. So, you know, there are connections that play on each other that all come back down to the mood symptoms that are so comorbid with Parkinson's. So that's something that's important to always think about. Autonomic dysfunction. So I mentioned some of this earlier when we were talking about multiple system atrophy, but of course it's a very big problem with Parkinson's patients as well. And not only for a quality of life, from a quality of life perspective, but also from a safety perspective. It's really important to identify orthostatic hypotension, not only, again, because you can treat it, but because it can contribute to injury and significant problems if the person goes untreated, because it can increase fall risk. Constipation is grouped in here. It will be present in nearly all Parkinson's patients, and usually many years before their motor symptoms will manifest. Again, this is something that you ask about and you do treat. I treat it fairly aggressively, just because I find that if we can stay on top of it, people will generally have a better quality of life, and it frees up resources to deal with other issues. Dysphagia is another thing that we want to think about and screen for, just because of safety concerns. Parkinson's patients, when they do get to the end of life, will almost always pass away from issues related to dysphagia and aspiration pneumonia. So that's important to be on top of. Sexual dysfunction goes into quality of life. So we spend a lot of time at most clinic appointments dealing with these issues, and when you're screening someone for the first time, they can be fairly valid and hints about whether someone really does meet the criteria for Parkinson's. Sleep disorders are a whole realm onto themselves in movement, in neurology, but also in movement disorders. They they're a big part of Parkinson's, and they're a big part of the premorbid, premotor manifestations of Parkinson's. The most classical thing you will see is something called REM sleep behavior disorder, which basically involves an inability for your body to paralyze itself while you're dreaming, while you're in your REM sleep. So the best way to elicit this history is not to ask the patient actually, but is to ask their bed partner. And you'll almost always hear a story of how there's someone who acts out their dreams, or how, you know, the bed partner will have gotten punched or kicked in the past. And in extreme cases, they won't even be able to share the bed because their dreams are so active and potentially dangerous. So this is something that, you know, is easy to identify actually on history. If you need to do a sleep study, you can do that. And again, there are treatments available. There's a lot of expertise in sleep neurology, and we work with our colleagues in the sleep field to optimize these patients, because it can have a big impact on the rest of their symptoms in terms of fatigue and daytime sleepiness. So that's something that I would encourage people to try to remember if they're thinking about Parkinson's in a patient they encounter. Now, you know, a lot of the things I've talked about, including the constipation and even the sleep issues, I mentioned as premotor markers or premotor signs of the disease. And people have talked about them even as biomarkers for Parkinson's. We don't yet have what I would consider a valid or a largely ascribed to biomarker, but there are a lot of efforts all the time to try to identify one. From a treatment perspective, it can be very valuable. You know, the lack of sense of smell, or the diminished sense of smell, is definitely something that people will experience 10 years before the onset of their motor symptoms. So it's always important to, you know, think about that, but also just think about other things that we can maybe identify before people actually need treatment for their movement issues. So, you know, I just said a lot of this, but the hyposmia is something that we think about and ask about. Besides the REM sleep behavior, the constipation, we do think that you know, focusing on identifying biomarkers and also tracking these markers in patients that have the diagnosis is still something that has yet to bear fruit, I think, in the field. But it's something that can be useful, at least when you're screening your patients. I want to say a few words about pathology now, and relate an interesting sort of idea, a nice unifying idea about the pathology of Parkinson's that helps us to explain symptom progression. So we talk about Lewy bodies, which are protein aggregates that will stain positively for synuclein. And this is also why some of the disorders that cause Parkinsonism are referred to as synucleinopathies. And essentially, the dopamine neuron loss that we see that eventually results in substantia nigra, you know, dopamine loss, is due to the progressive aggregation of these proteins in this structure, but also in other structures in the brain. The theory or the hypothesis that I wanted to share, that I think unifies not only what's going on pathologically, but also symptomatically, is something we refer to as the BRAC hypothesis. So based on a paper that came out in 2003. And essentially the idea here is that these Lewy bodies, these synuclein positive Lewy bodies, these proteins, get deposited more ventrally in ventral structures of the brain stem. And in fact, the deposition probably starts even further down, and sort of get deposited in an upward in a rostral fashion, so in a fashion going upward, and that progressive deposition moving up the neuraxis is actually important for understanding how symptoms progress in classic Parkinson's disease. So in this first part here, you can appreciate that, you know, the Lewy bodies will be deposited further down in the brainstem, And this might, impact things like sleep-wake cycle, if you're thinking about the locus coeruleus, where noradrenergic neurons are largely based, but also the dorsal the dorsal vagus nucleus is impacted, and this can also have effects on things like salivation, mastication, dysphagia. As the protein deposition moves rostrally, you eventually get up into the midbrain, where of course that's when we'll typically see the dopamine producing cells of the substantia nigra get affected, and you'll see movement symptoms emerge, like tremor and stiffness. And then as the deposition continues, that's when you move into cortical areas, and there is sort of a semi-organized way that the protein would be deposited cortically, starting in the frontal cortex, and of course sort of radiating around, and that's when you would see the more high-level executive symptoms that will often lead to dementia. So, this is a theory. It's a theory that's based on gross anatomy and on dissection of brains of deceased patients with Parkinson's. It makes a lot of sense if you think about how things like constipation and anosmia are considered premotor signs that will often precede the classic symptoms by many years. But of course, it doesn't account for everything, and it doesn't account for all presentations of Parkinsonism. And I'm hopefully many people will be thinking to themselves that he just told us that Lewy body dementia and Parkinson's were the same pathophysiologically, and yet Lewy body has dementia at the beginning. So the Brack hypothesis doesn't explain that, and I think that's why we can only refer to it as an appealing hypothesis at this time, but nonetheless one that I wanted to share because it is I think a lot of neurologists do find it compelling. So if we now focus on how we diagnose Parkinson's, just for the last part of the talk here, a mini quiz, normally I would be able to engage the audience, but just going through the different possibilities, hopefully I've given you a sense already that it's not necessarily by doing a brain scan, it's not necessarily by looking at measures of autonomic function, such as cardiac sympathetic denervation studies, and it's not necessarily by testing the patient with medications, seeing if they get better. Really the cornerstone of diagnosis is based on the clinical presentation and the exam, and then thinking through the differential, as we've been talking about. So there are many different diagnostic criteria out there. The ones that are commonly used nowadays date to 2015, published by the Movement Disorder Society, and there's a nice Canadian tie-in there because many of the authors were Canadian neurologists, and the lead author was a neurologist who works here in Montreal, Dr. Postuma. And I think this is probably, for now at least, the most widely adapted definition of Parkinson's from a diagnostic and research perspective. So you want to talk about bradykinesia as being a necessary thing to have, combined with either tremor or rigidity. So you don't need both. You just really need the slowness. And then there are a number of other criteria that we can go through. I'm not going to go through them in detail today. I'm just going to show you, basically what they look like. So supportive criteria would involve things like responding to the medications, experiencing side effects from the medications, which is just another way of responding to them, having the classical tremor, and then of course having paraclinical imaging findings like autonomic denervation. You want to go through your red flags. Again, this isn't meant to, I'm not going to go through this in detail. It's more just to give you a sense that there are a number of things that can turn you away from Parkinsonism or classic Parkinson's, to do with progression, having to do with other signs and symptoms. One of them here, for example, is early bulbar dysfunction. So when someone presents with Parkinsonism, but also a lot of weakness in their face and their face muscles, you have to think of things like motor neuron disease. And it's happened to me on a number of occasions where the patient ends up having ALS, for example. So, you know, when we talk about an established diagnosis according to these criteria, we talk about ruling out the absolute exclusion criteria, having at least 2 of the 4 of the supportive ones that I just showed, and then of course having no red flags. You can modify this to a probable definition, which just kind of loosens the criteria a little bit, as you can see. So you're still talking about excluding the absolute exclusions, but you can sort of allow a red flag if it's balanced by the supportive criteria. Now getting into imaging in the last few moments of the talk, does it have a role in Parkinson's disease diagnosis and in thinking about Parkinson's? The official answer is that it's not necessary to make the diagnosis, but of course it can be useful, and we do in a thoughtful way often consider imaging studies to help us make the diagnosis, especially when we're thinking about secondary causes. So structural MRI is one of the more common things that we'll think about if we want to send someone for brain imaging. It doesn't have a whole lot of value in thinking about Parkinson's, to be honest. What you might see is some generalized atrophy and volume loss. And usually you're going to think about an MRI if you're thinking about a mimic, or if you want to identify something obvious like vascular Parkinsonism, or even a neoplastic process that's going on. FDG PET is something that isn't commonly done either, but can be done if you want to think about distinguishing typical Parkinson's from the atypical forms that I talked about earlier. So here we see an FDG PET glucose scan in a PD brain versus a multiple system atrophy brain. And you'll notice here, according to these arrows at least, this is pointing out the striatum, the area of the striatum. And as compared to the Parkinson's brain, where there's some red areas here indicating that the glucose metabolism, that metabolism is absent in MSA. So this is sort of considered to be one sign that's more consistent with an atypical variant if you're talking about striatal glucose use. Again, not something that we'll often use to clinch the diagnosis, but can be done. DaTScan, I'm sure to many in this audience, I don't need to explain or introduce. It's something that we're using more and more in the movement disorders community when we want to rule out mimics. So we're talking about looking at presynaptic dopamine transporter imaging. And it's a really nice index of dopamine levels. And we can see here in a Parkinson's patient that has symptoms more prevalent on one side, here on their left side, because the right striatum is what we're looking at here. That nice comma sign, the comma is not completed here. So that's a nice illustration of how you might be able to make a statement about presynaptic dopamine transporter density in a brain with a Parkinson's patient. We know that there is a role for this type of scan in working up patients when you're really not sure and when your exam is still ambiguous. Sometimes it's not just the exam, sometimes it's the history as well. And often as well, it bears mentioning that even movement disorders neurologists can be wrong, and they can be wrong for many years. There's an interesting statistic here that up to a quarter of patients who have been treated as Parkinson's will actually, after they pass away, if we do an autopsy on their brains, will have some other disease that was going on at the time. So that's a humbling reminder that we always need to be questioning and rethinking our diagnosis, because we can be fooled. And here's just a nice table that I wanted to show for some of the more classical indications of the DaTScan. We're going to think about this when we're talking about essential tremor and differentiating it from Parkinson's, because it can look quite similar. And the other one that I find compelling is drug-induced Parkinsonism, or tardive Parkinsonism, from classic Parkinson's. It bears mentioning of course, though, that the DaTScan is not going to help you differentiate Parkinson's disease from the atypicals. So, you know, this is an issue of knowing what the test can tell you and choosing it appropriately before you order it, because the interpretation is going to be, you know, if you don't ask the question in the right way, the interpretation is not going to help you. So here is just another interesting figure from a recent paper, basically just showing that you know, the DaTScan can actually confirm the deficiency about 90% of the time. And if we actually look at, this is a meta-analysis that was done on people who had DaTScans, and they computed sensitivity and specificity from this collection of data, and we can see 95 and 93%, at least for discriminating essential tremor from PD, which is the column here on the left. So, you know, this can be a very good, very useful test in the right circumstances. Also, the second one from the left here is differentiating from a tardive or a medication-related Parkinsonism. So the large blue column indicates that there was a change in diagnosis, which means that the DaTScan was actually pretty important. So in the right situation, again, can be very useful. The last scan that I wanted to, or the last imaging modality I wanted to make people aware of, it's a relatively new kid on the block, neuromelanin scanning. Not something that we use clinically, but I think could have really interesting applications in the future. The nice thing about it is that it's a sequence of an MRI, it's an MRI sequence. And again, it helps us to identify this pigment, which is sort of a byproduct of dopamine metabolism, and that will collect in places like the substantia nigra over time. So in a normal person without Parkinson's, there's a fairly high signal that comes out in this area if we're imaging for, if we're running this sequence for neuromelanin, and we can see that demarcated here on the left. But if we look at the brain of a Parkinson's patient, there's almost no signal there. So it's a fairly sensitive marker for dopamine loss. And conversely, it can also be used in situations when you want to look at psychosis, when there's excess dopamine tone. And that's been shown in this beautiful paper by Cassidy et al. In 2019 in PNAS, I believe. I would encourage people to read it if they haven't seen this paper yet. So, you know, that this is just another tool that I think will become likely part of the toolbox as time goes on, because it does offer us another way of having an in vivo sense of what's going on with dopamine in the cardinal brain areas that are impacted. So with that, we've got about 8 minutes left. I just want to leave you with a few important messages. Hopefully I've been able to illustrate that when we talk about diagnosis of Parkinson's, we really want to focus on those cardinal clinical features that we can examine clinically. And bradykinesia, of course, is the main one, combined with tremor and rigidity. Pathologically, we always talk about synuclein as the main component of those Lewy bodies that get deposited in that ascending fashion to account for symptoms. And of course, you know, thoughtful consideration of different imaging modalities can help us, but it's not necessary to confirm diagnosis. And I think things like the DaTScan and the new neuromelanin scans are really interesting alternatives to and tools to have available in that regard. So with that, thank you very much for your attention and for the invitation. And it's my pleasure to answer any questions if there are any.
Perfect. Thank you so much, Dr. Richards. This was a very, very great presentation, especially for us. I think we should never forget how important the clinical side is to any disease we are trying to help with in our imaging modalities. So I think your presentation was too good. We don't have any questions yet, so I guess I'll be spoiled to ask you one myself. It's more of a personal question. So, I mean, one of the radio tracers that's most exciting in the nuclear medicine community now is the the DaTScan. And I was wondering, what's your personal experience with it? Have you been doing it in some patients, or?
Yeah, so thanks for the question. You know, DaTScan is something that I mean, I'm a relatively new movement disorders neurologist. I've only been in practice for a couple of years now, as you know, Peter. And it's something that here in Montreal, I think we're really lucky to have a lot of expertise. And in most of the bigger Canadian centers, there is expertise on this. In my practice environment, we have the ability to do that scan. And, you know, in terms of who reads those scans, that's based out of McGill. So, you know, it's something that we do use. I will admit that I probably don't use it as often as I should or could, mainly because I tend to focus more on the clinical aspects for the first little while to differentiate things. But, you know, just today, in fact, just this afternoon, I saw a patient in my clinic who, with a question of is tardive Parkinsonism related to neuroleptic use, risperidone use versus idiopathic Parkinson's. And the patient herself was quite affected and still very sort of psychiatrically, you know, had a lot of symptoms. And so she wasn't able to provide a very clear history of the chronology of her neuroleptic use and also her Parkinson's. And the exam itself was not really helpful, both because of her compliance to the exam, but also because she didn't really have that classic sort of asymmetric picture that I explained earlier. So she's someone that, you know, we're going to send for a DaTScan, because I think looking at her dopamine receptor concentration is going to basically give me the answer. And it will be important as well from a treatment perspective, because we have to decide with her psychiatrist whether we want to stop her neuroleptics at the risk of worsening those symptoms, or switch her to a different neuroleptic, which can also cause problems, versus just, you know, going forward with a Parkinson's treatment. So I think that's a really poignant example of how, you know, in certain situations, a DaTScan is a fantastic tool. And in Montreal, at least, I can say that we're very lucky to have a lot of readily available expertise.
Great. We have a question. Thank you, Dr. Richard. We have a question from Kathy Yip. A number of family doctors have asked me about doing DaTScan in patients they suspect have PD. Do you think family doctors should order it, or should it always be ordered by a movement neurologist?
Well, that's a really good question. I think any physician who feels comfortable with Parkinson's disease and with the ability to diagnose Parkinson's disease, and, you know, I just went through it. I think certainly family doctors can make this diagnosis and have this expertise. I get a lot of referrals from family doctors that manage Parkinson's for years, that they've diagnosed, and only refer to me when things get complicated or when they're dealing with a lot of comorbid symptoms, or, you know, treatment refractoriness or something like that. So I think that the expertise certainly is there for general physicians to use these tools. And I would just say that, you know, it should be, again, the right reflection has to go into it when you're ordering the scan. So you have to, first of all, feel comfortable with, you know, knowing how to recognize Parkinson's. And you also have to feel fairly comfortable thinking about the differential of Parkinson's. And if you can do those things and you're in a genuine situation where, you know, you're not sure if it's one or the other, I would say absolutely family doctors can make the referral. But I would also say that some people just may not have that same kind of experience and that same kind of exposure in their practice. And for those types of people, you know, referring to a general neurologist or a movement disorder specialist is always an option. And we're always very happy to get those referrals, because those are the questions we like thinking about.
Great. Thank you. We have another question, might be the last question since we don't have much time. So by Dr. Karine Provost. In which clinical situation would you favor doing an MIBG cardiac study versus a DaTScan? In your experience, is it useful in distinguishing PD versus other Parkinsonian syndromes, such as MSA, etc.?
Yeah, that's a fantastic question. Thank you for that question. So doing a cardiac denervation study is something that, you know, I have done, but not a lot of. And again, the reason is because often if you just focus on the clinical presentation and the progression, so those are the patients that I'll see not every 6 months, but I might see them every month or every 2 or 3 months, and just do serial exams, and also, of course, look at their other symptoms and their non-motor symptoms. That can often give you a fairly good hint. Doing the cardiac scan is going to be useful, however, if you want to differentiate amongst the different atypicals, because doing a DaTScan, as I showed in that table, won't. So, you know, looking at presynaptic or receptor density isn't going to differentiate PD from PSP from MSA, not with high validity. So I say that's an issue where you might want to actually look for dysautonomia and try to objectify your dysautonomia more. But it's a very good question. And again, my focus is usually more on the clinical presentation and progression. And I'll try to be more careful and judicious when thinking about other tests.
Thank you. We actually have one last question, part of which you've answered by talking about your experience with DaTScan. Here it's, what are your common reasons for getting a DaTScan? How many have you requested in instances? Is it covered by the province financially? A-suit.
So the common reasons for me, and I think this part I might have alluded to already, but I'll often think of it when there's high degree of suspicion or ambiguity between essential tremor and Parkinson's, or drug-induced Parkinson's, or tardive Parkinson's and idiopathic Parkinson's. So those are the two situations I've ordered the DaTScan in. How many have I ordered? Well, not a whole lot. Probably maybe between 5 and 10 in my career so far. But it's a short career, so I expect that number to go up over time. You know, again, this is a fantastic, sensitive, high-value test when you order it thoughtfully, and when you have the resources to do it. But you don't necessarily need it if you have the ability to follow the patient closely, or if you have the ability to consult a movement disorders neurologist to answer some of these questions.
Okay, we'll go for one last one. How about that? Oh, no? Oh, okay. I guess the time's up. Oh, okay then. Okay, we're waxing waning. We'll go one quick last question. What are the most common causing drug-induced Parkinson's in your patients?
I'm sorry, Peter, can you just repeat that? You cut out for a moment there.
Sure. It's one last question. Peter Duchat. What are the most common culprits causing drug-induced Parkinson's in your patients?
So you cut out again, but I got the gist. So I'm just gonna try to interpret what you said. I think the question was, what are the most common drug-induced Parkinsonism? What are the most common culprits in terms of drugs?
Yeah.
So, you know, the most common by far is the first and second generation antipsychotic medications. Things like Haldol, even though people will tell you Haldol is not that associated with it. Risperdal, any kind of old antipsychotic. You also see it with Abilify, which is the third line. You do see it with antiemetic medications. So Maxaran, which is a very common treatment for headache and migraine, and it's used like water in emergency rooms, can produce Parkinsonism. And then the other one to be aware of is lithium. Lithium will, people will talk about a classic lithium tremor in a bipolar patient, but it actually can produce more of a Parkinsonian constellation of symptoms if people take it chronically. So those would be the big ones that I would caution people to think about.
Great, perfect. Well, thank you so much, Dr. Richard. I guess that's a wrap, and thank you for everyone participating. I'll give the words to Nicolas right now. Thank you, everyone, again, and we'll see you on the next webinar series.